because it is time. Welcome, everyone. Thanks for joining us today. I'm Deidre Smith, and I am the Director of Clinical Affairs for World Vasectomy Day. As you enter, your mics will be muted. During the discussion, if you wish to participate, please raise your hand, and when called on, unmute your mic under the screen to the left. To raise your hand, you'll find this function under Reactions, down to the right. After the case details are given for the presenter, we're going to have a quick survey in English and then in Spanish to get your initial reaction. We want to know what you would do in this case if it were yours. Please answer only one of the preliminary surveys for each case, or either in English or in Spanish. And after the discussion and the comments by the ethicist and moderator, we will have a second survey asking whether your opinion has changed. All questions will appear first in English and then in Spanish. Again, please answer only one. We'll then post the results so we can see how closely we all agree. As always, we welcome comments and questions in the chat box. We will send the dialogue out a few days after the webinar. When we get everything together, we'll be sending everything back to you. If you want to stay on afterwards and keep the discussion going, we're going to host the Zoom another 30 minutes or so after the official time. Also, if you want to receive a CME credit for attending today's session, we'll post the link in the chat, and you can copy that link, and then you will be able to register directly with the Laval University to get your credits. The webinar is also going to be recorded, so it can be accessed later for CME credit or your review. We'll also provide links to the evaluation form that we ask everyone to fill out at the end of the session. This is important feedback for us because it helps us keep our programs going. So please fill out those evaluation forms. Finally, if you would like to make a donation to help World Vasectomy Day continue this type of programming, Dr. Edgar Guarin has a few words to say. Edgar?
Well, thank you very much, Deidre. We're very happy to be here once again. I just want to welcome everyone. On behalf of the organization of the movement that we have, I just want to remind you that World Vasectomy Day is a movement that promotes participation of males in reproductive health. And as you know, for several years, we have counted on the effort of the founders and the ridiculous.
None of this is possible without the efforts of all the World Vasectomy Day staff who put together the announcements, send out the notices, and manage the tech of this webinar. Thanks also to our translator, Laura Reinisch, and to DKT and Bergstrom for financial help. Thank you all. Now I'd like to present two people who will help us sort out the ethics of some thorny cases today. First, the man who many of you may know as Dr. Snip. He's a Seattle native and for over 30 years has collaborated with other interested vasectomy doctors to advance modern vasectomy technique. In addition to his private practice, Dr. Wilson is a clinical associate professor in the University of Washington School of Medicine, and he's a fellow at the American Academy of Family Physicians. We are fortunate to have Dr. Chick Wilson as our moderator today. I'm also very pleased to introduce Dr. Gwendolyn Quinn, a medical ethicist who has kindly agreed to join our discussion today. She is the Livia Wan Endowed Chair and Vice Chair of Research in the Department of OBGYN and Professor in Population Health and the Division of Medical Ethics in the New York University Grossman School of Medicine. She is a member of the NYU Faculty Senate and chair of the department's Appointment, Promotion, and Tenure Committee. Her research focuses on patient-provider communication across a variety of topics, but primarily in reproductive health and cancer in adolescent and young adults, and access to care for minority and underserved populations. She is the author of over 300 peer-reviewed papers and book chapters, and has received more than $3 million in federal and foundation grant funding. We're fortunate to have her insights in the cases we are presenting today. Chick, it's all yours.
Great, thanks you, Deidre. It's a pleasure to be here. And my role as moderator is to help everyone participate as much as they want to in the discussion today. It's not a lecture, it's a discussion, so it all counts. It all depends on you. So we have three presentations that'll each have about 15 minutes for our discussions. And I'm so thrilled to have Gwen Quinn here to comment, and we'll kind of reserve her to the end of each case to reflect on what's been said and maybe the things that we've missed or not said, and give us some insights from that point of view. But most of it is open discussion with you guys. I want to make sure that everybody feels comfortable participating if they want to. And I want to test that little function of raising your hand, the electronic raise your hand thing. Would everybody please click on the reactions and then raise hand thing so you get the feel for it. Great, that looks wonderful. So when you do that, I'm going to have some helpers spot people who are raising their hands. Okay, lower your hand now. Everybody lower your hand. Good. So when your hand's up, we're going to read that as you're ready to contribute to the discussion, and I'll try to call on as many people as possible to get as many different views on each of these cases. Without further ado, I'm going to ask Dr. Michelle Lebrec in Quebec, Canada, one of our World Vasectomy Day board members, to present the first case, an interesting case that he had, and then we'll discuss it. Michelle?
Yeah, with great pleasure, Chick. Thank you. I'll share my screen to present this case. Let me just start it up. And here, meet Jack. Actually, this man had a vasectomy with me about 25 years ago. And at that time, I was using simple ligation and excision for occluding the vas and was having many failures. And despite my advice, like a third of men with vasectomies, he did not take a semen test. So about a year later, he calls me because his wife was pregnant. Bad news for both of them. I said, Jack, bring a semen sample to the hospital lab. If it confirms that your vasectomy failed, I'll simply repeat the procedure. But his wife had a secret. She had a boyfriend, and she knew that her husband was not the janitor. So to be sure that the pregnancy appeared to be due to a failure of the vasectomy, she offered to bring her husband's semen sample to the lab. But instead, what she did, she stopped to her boyfriend's house, changed the sample, and brought the new sample to the lab. And the semen sample, of course, showed 1 million of motile sperm. So I repeated my patient's vasectomy. A week later, his wife went to the hospital and got an abortion. So in the end, everybody was happy. He had a new vasectomy and she was not pregnant anymore. Now you will ask how I learned about this story. When my patient's wife went to the abortion clinic after she had his vasectomy, she revealed her secret to the attending nurse. And guess what? This nurse was also my assistant when we repeated my patient's vasectomy a few weeks earlier. She didn't know the story at that time, of course, but told me all about it after the abortion. Now, what should I have done? And this is what I'm asking you, and I will give back the screen and you can answer the survey.
Thank you, Michelle, and Matt, go ahead and put up the poll, and anyone who feels like responding to the questions on your screen, you can click what you might do if this were your case, and we'll tally those and show them later. So just click one of the 3 boxes and then click submit. You can do it either in the English version or the Spanish version, and then that in a moment that box will disappear from your screen. So Michelle's case brings up several interesting principles of ethics, honesty, transparency, to your patient the beneficence. Do you really want to spoil the happy outcome of this case by bringing out the real truth, and your obligation to first do no harm? I'd like to see who would like to speak to any of these ethical issues. And I, Deidre, can't see you in the chat room or any hands. Okay, Dr. Feldbauer, I see your hand is up. Would you please comment?
I think this all depends on the whole question of patient confidentiality. And purely from that point of view, I don't see that you can do anything. You just keep quiet, keep mum.
Okay, so that's certainly not going to do any harm. I mean, the procedure's already done and everything, and so you're not going to spoil the outcome. But what if you hadn't done the procedure? What if he was on your schedule to do? He postponed it. She had the abortion, and you found out about this, and now you think you're going to do an unwanted or an unneeded vasectomy. Would that change your mind on that, or other comments?
I think that's, yes. If you're asking me the same thing, then I think it clearly has to be different, because you've now got a duty of care to your patient,
Right.
and I think what I would do is actually try and contact the wife first, and explain what your duty is to her husband, and get her to sort it out.
So you would contact the wife first to see if you could get her to tell her husband about it.
Yes, and also to say that you have a duty of care to her husband not to perform an unnecessary procedure, because that could be regarded as a criminal assault.
Understood. Let's see, Mike Henchy, you have your hand up. Deidre, I still am not getting a list of hands that are up. If you can forward that to me, Mike.
Okay, Inez. I have.
Yeah.
What?
Okay. Yeah. I'm sort of following up from Tony's comment there. I'm not sure you could contact the wife, because there are, again, issues of confidentiality here. That, you know, your patient was her husband, and so he has a right to preservation of his clinical information, as it were. But having said that, yeah, I mean, to raise this issue at all and bringing it out into the open, the fact that she had a sort of unintended pregnancy as a result of an illicit affair, could have a devastating effect on their marriage. So yeah, I think definitely you don't say anything, and let sleeping dogs lie, as it were, because as Michelle has said, the outcome was happy for everybody.
Now you're saying that you're protecting your patient's privacy and confidentiality by not telling the wife, but you wouldn't be disclosing any patient information to the wife, only what you'd heard from her hearsay, right?
Well, except that, you know, you're acknowledging to her that you've carried out a vasectomy on her husband,
Okay.
which she may or may not have known about. So,
I see.
you know.
Okay.
Yes.
Okay. Anyone else want to comment on that? I'm scrolling through. I wish I had
I can.
Go ahead.
If I can go ahead. Well,
Yeah.
I'm gonna second a comment that Sarah made in the chat. Right, we have to remember that there are two different patient relationships here. I would think that, you know, the patient relationship between the wife when she had the abortion, and the patient relationship between the patient, the vasectomy patient, and the clinician who's doing the vasectomy. So I would have to start with the fact that one of those patient clinician relationship confidentiality has been broken, and is the fact that the nurse disclosed the information that she obtained during the procedure. So that by itself is a problem. I think that would be a major dilemma at that point. as heartbroken as many of us will be knowing this information, the problem is disclosing that hearsay information at the same time would perpetuate that the break on that confidentiality. So my conclusion will be, well, unfortunately, I cannot say anything, and I would just continue, with that. That would be my take on.
Thank you, Esker. So your point is that disclosing hearsay information is not.
I have to look after my now.
Sorry.
What was that? I'm sorry.
Go ahead.
No. I was just going to say, as much as I have to look after my patient, I cannot look after my patient by actually breaking, continuing the break of confidentiality of a different patient clinician relationship. Granted, if this was putting the patient at great harm, at the end, I would just involve authorities if something meant that this gentleman was going to be harmed physically, in the sense that he could lose his life. Yes, we are. If I go back to the example that you gave afterwards of what if I learned this information before pursuing the vasectomy, I don't know what I would do in that situation. That's a bigger dilemma. But after the fact, just say anything.
One more comment, and then I want to turn to Dr. Quinn to summarize and give us her insight. Doug, your hand's up. Doug Stein.
Yeah, I agree with Esker that it's compelling to think about what would have happened if that information had reached Michel before he had done the vasectomy. I think what I simply would have done is told the patient, we really like to double check on this. Could you bring a semen sample in, or better than that, produce it at the lab to get corroboration? Because sometimes lab results are mixed up. And who knows what happened in that lab. So that would have been a little easier. Michelle's problem is a little harder because it's after the vasectomy.
Right. Or another possibility is that maybe it was the husband's child, maybe or pregnancy, maybe he had a failed vasectomy as well as there being a boyfriend involved. Anyway, I'd like to turn over to Gwen to comment on this case and our perspectives.
Yeah, thank you. And thanks for everybody's comments. I think just really briefly, as you mentioned in the beginning, we usually apply the 4 principles approach, so did the patient have autonomy? In some ways, it can be argued, like the last person just suggested, that perhaps it was not autonomous, the fact that he did not bring his own sample or did not have his own sample collected in the clinic. There's any number of things that could have happened in transport. I think also in issues of doing no harm, there really was harm already done by, as many people noted in the chat, by the nurse breaking confidentiality. We like to teach our medical students and our nurses to go with first source information. So if they come and they say, oh, my friend told me he read an article and it said this, if you didn't read the article yourself, you cannot be sure that that is the information. And even if that information, were told to you or you overheard it, it was not given to you to share. So I think in this particular case, the physician did everything that he or she could have done accurately. And of course, when we hear about these kind of things, they stick in our minds, overnight, but there would have probably been more harm done to disclose secondhand information or in any way to insert yourself in between the relationship, of the patient. So I think in this case, the physician probably can feel confident they did the best that they could do at that time.
I hear you saying more harm done and valuing in some way the fact that, like Doug and Esker said, there wasn't any imminent harm. The potential for doing harm by disclosure is more than the possibility of doing good by revealing it.
Right. And in the case, I think in the alternative case where the procedure had not yet been done, the suggestion that is something that I would have offered had this case been brought to the ethics board, that the patient produce a sample in the clinic.
Very good. Yes, that would solve a lot of the uncertainty there. Very good. There are cases. I would say a more common case that we've probably all seen if we do enough vasectomies is that the PVST is negative. There's a pregnancy and the test is negative, and we're faced with how we word that, how we say it to the patient, where obviously statistically the chance of a sperm donor involvement is much higher than the chance of a single sperm having eluded our testing, but that possibility is there, so we have to leave those possibilities open and counsel patients and their wives about that. Here's a quick question before we end this topic to people. A show of hands. Would you agree to do a repeat vasectomy if the patient and his wife, in that case of a negative PVST and a pregnancy, and they said, yeah, we really don't feel confident without having that vasectomy reversed? Would you do another vasectomy when the PVST is negative? Anyone want to just raise your hand if you would? And how about a thumbs down if you wouldn't? I don't see any responders on that. Okay, you can do the electronic raise hand if you would, and a thumbs down if you wouldn't. Okay, so we have a few on each side. Well, I think we'll leave that for that. Let's do the post poll. We have the results of the original question on the screen now. About the 13% of doctors saying they would call and tell the patient everything. 46% waiting, but if asked, would reveal what they had heard, and about 41% refusing to repeat the hearsay. So let's put up the post poll and see if anyone changes their mind on that. And while that's coming up, I'd like to introduce our next case presenter, Esker Garin. You've heard from him already, another board member of World Vasectomy Day, practicing in Des Moines, Iowa. So please answer this poll question while Esker is presenting his next case. And actually, this case is was submitted by Tony Feldbauer. And Esker, are you ready to present that one? I'm not hearing Esker.
Sorry, I'm having
Here.
some difficulties here.
Maybe I should read it, Esker.
Yeah, but I'm sorry. Yes, I think.
Okay, and I did see Tony here, but I think he may not be prepared to read it. So, okay, so this is an 18-year-old that came to Dr. Feldbauer, and I want to point out this was 15 or 20 years ago this happened, and that's pertinent. This 18-year-old came with his mom and wanted a vasectomy. The reason is that his mom had been diagnosed with Huntington's chorea, and there was no way he wanted the 50% risk of passing it on to any of his children. His mom was supportive. Dr. Feldbauer explained that within 20 years, there could be new treatment developed for Huntington's, or even a cure, or even genetic testing of embryos. But the patient was adamant that he wanted the vasectomy. Was it right that Dr. Feldbauer went ahead with the vasectomy on the basis that this was an adult in his right mind and legally capable of making his own decisions, especially as his mom was there? It was also supportive with his decision. Or would it have been right to refuse to give him treatment that he was legally entitled to? So a vexing problem, a difficult situation. Just a couple of things. Huntington's chorea, of course, is an autosomal dominant trait that doesn't manifest until late in life. So this patient wouldn't have known without that he was, whether he was or wasn't a carrier. So based on that, there would have been a 25% chance for each of his children to be a carrier of Huntington's and perhaps come down with the disease later in their life. As I said, this occurred some time ago. So given that the risk that the patient may have a child with Huntington's disease, which is fairly severe, what's your role as a doctor? Are you just informing the patient, or do you have a role to try to prevent Huntington's disease? Anyone want to comment on that? I'm looking for raised hands.
Mine's raised, but no.
Deidre Smith, I see your hand was raised.
I'm putting it down. There's Melvin Nasaka.
Okay. Yes. Okay. Dr. Nasaka, please.
Lecture and the discussion. Hope you guys can hear me.
Okay.
In my case or situation, I'll try to thoroughly explain to the patient about their options, because most of these patients come to us thinking that for them they've got it all, like they know what they are going to do, but in actual sense, they don't even know why they are doing so. So there could be a misconception or a misunderstanding. So of course, before letting the patient undergo such a procedure, I would first thoroughly explain the pros and cons of that procedure and the possible management or treatment and outcome, so that at the end of it all, after thoroughly explaining to the patient, he decides for himself. Was the patient above 18? Or here in Uganda, we consider patients above 18 to be adults, but then below, those below 18, we consider assent, something to do with assent. So, as the patient above 18?
Yes, the patient was 18. Yes, right.
Yeah,
Right.
so I would consider that first. Thank you.
Right. So thoroughly inform the patient of the risks and benefits. So that was 15, 20 years ago. Now we have genetic testing for persons who have the gene for Huntington's. We can check their karyotype and find out if they do or don't have the gene. So if that were the case, and the same young man said, I want to get this vasectomy, I want to get it now, and you said you explained that in all the information that there is genetic testing, and the patient didn't want to get the testing because some people don't want to know that they're going to have a terrible disease later in life. Would the patient be fully informed? Would you be able to fully inform the patient? Would you accept the patient's rejection of the genetic test? Ronald, I'm sorry, Atabembere, you've had your hand up. Would you like to speak to that?
Okay, thank you so much. I think in this situation, this patient, of course, has a 25% risk of that illness, but if he's not able to take up the genetic test because of fear, it will be a difficult situation to decide to do vasectomy or not, but always goes back to the patient. But as a health worker, my role is explaining to the patient, and then he takes up the right decision. I wouldn't do a vasectomy straight away because I can't tell whether he has a gene or not. Yeah.
So I think I heard you say that if you don't know that whether they have the gene or not, you couldn't, in good conscience, do the vasectomy even if they asked you to. Is that what you said?
Yeah, it would be unfair for me because of I would have stopped their reproduction.
Yes. Dr. NDE. Yes. All right, unmute your mic, sir. Dr. NDE, there you go. There you are. There you are.
Look, I think in both those cases, I would eventually do the vasectomy, but there would be a time that I'd have to assess whether they'd had enough information to give informed consent. In the first case, I think it'd probably be a bit easier because he'd been probably talking to his mum for years about it, and he probably would have a lot more information. The second case would be a little bit more difficult in that you'd probably want to give him a bit of a cooling off period before he raced into it, and give them a lot of information about irreversibility and what the consequences are if they change their mind. So try and minimise the risk of decision regret.
Okay, but what if you knew that the patient was going to have let's say his test was positive, as a matter of fact, his genetic test was positive, and you knew that he had then a 50% chance for each of his children to have Huntington's disease, a very bad disease?
I think that's irrelevant. I'd still do the vasectomy if with informed consent, that's what he wanted.
Okay, all right. Other points of view? Yes, Rosanna Rahman.
Hello.
Yes.
So I do agree. I would do the vasectomy, and what I just wanted to point out is that this is the whole point of informed consent. It's not that we necessarily agree with what the patient would decide in the end, but we give them all the options, even if he just wants to collect sperm in case he would like to, in case there is genetic testing or testing of the fetus in advance that has developed, that develops in the next 20 years, and he's still interested in being a parent. But he could get pregnant, he could get someone pregnant tomorrow, and he doesn't know what the end result was, and then they go through the trauma of having an abortion because he's so worried. Like we aren't living his life. They are his priorities, and all we can do is give him the options that are available today, and anything that might be available soon in the future. And whatever he decides, it's his decision. Otherwise, we revert to being a patriarchal and patronizing medical system. I would do the vasectomy if once fully informed consent has been done. I would do it if that's what he chose.
Okay, great. So I presume too that if it was a young person, an 18-year-old who had no genetic problems, but just didn't want to bring any children into this tormented world with conflict and climate change and all of that, you would allow them with fully informed consent to go ahead and have their vasectomy, right?
I would. And what we don't know is that potentially they had what they might not be telling you, and what might have instigated the decision is that they've had an extreme amount of trauma in their past, and
sure,
they're barely coping with their life, never mind bringing another child into it. I mean,
okay,
I would advise that they potentially store sperm, especially nowadays where it's very possible, in case they change their mind.
Yes, Doug Stein is 2 thumbs up on that, and thank you. So let's make the question a little bit more difficult then. So say the patient would want to have children if the risk of his passing a genetic problem to his child weren't too bad. So maybe it's a lower, let's hypothetically say it's a lower morbidity genetic disorder like deafness or dwarfism or I don't know, psoriasis or something like that. And maybe you're not sure about what exactly the risks are to the offspring. Would you consider referring them for genetic counseling, for example?
Yes, I would let them know that whatever they decide, I'm happy to respect their decision, which may include doing the vasectomy. But that before I would do it, I'd want them to have a discussion with people more knowledgeable about their genetic condition than myself.
Okay. Anyone else who would not only advise their patient to get genetic counseling or more information about their particular concern or their disorder, or even require it? Let's see. Anyone who would require it, just put your hand up and let me call on you for a quick comment. Mike and somebody who hasn't spoken yet, Abdallah Mixon. Can you talk to that?
Yeah, thank you very much. I'm from Tanzania. For me, I think the first issue I have to do the vasectomy after discussion with the clients, informing the advantage and disadvantage. And also, I would not do straight on the day has come to my clinic. So I'll give time and then so that he can discuss, he can weigh out. If it comes times, then he come back and say, okay, I'm going to, I have agreed to do vasectomy. I will do it because I'm afraid if I can say I cannot do that, possibly get the child having that problem. So the possibly psychologically affected my clients. So that's what I think about. Thank you.
Thank you. Okay, who else would like to expound on this particular set of ethical dilemma? Looking for hands. I'm sorry, I'm not sure I can see everyone at once. Tony Feldbauer. Tony, I think I see your hand up.
Yeah, thanks, Chuck. Yeah, as you know, this was my patient, many years ago. Unfortunately, I can't contact him. I don't know who he was after this time. The other two interesting things is that he actually had a younger brother who was also very interested in potentially having one, but he never came back, so he didn't come to see me. But it's actually quite reassuring that most people have actually, in a sense, supported my decision from those years ago. The only thing that I did miss out on, perhaps, is that perhaps I should have sent him away and say, look, come back in a couple of weeks' time if you're still there. But I did actually give him all the information that we've been talking about. Thank you.
Yeah, good point, Tony. And many of us have taken to offering vasectomy as a one visit procedure, because to require 2 visits raises huge barriers to access to vasectomy for so many people and put so many women at risk. That early in the 80s I did that, and I've not regretted it. But it is not uncommon for us to think, let's give this more time in this particular case. I'd like to turn it now to Dr. Quinn and see what insight she can give us on this case.
So this has been a really interesting discussion. And I think the point I would most underscore is something a participant said earlier, which is, as clinicians, it's our job to give patients all of the information that they need to make the decision that's best for them, and not necessarily what we would do. But one thing that I didn't hear is kind of a dissection between maybe probing a little to wonder, was the patient concerned about becoming a parent in the future because they were concerned and about their own health and would not want to leave, in addition to potentially, transmitting the gene, did not want to leave their partner a single parent, or to be an incapacitated parent? Or was their primary concern passing on the gene? Because, well, we didn't have this 20 years ago, but now we have pre-implantation genetic testing where embryos can be tested via IVF prior to implantation. So we know which embryos are affected or not. We actually have had a case of a patient who chose not to have their own testing, but wanted all the embryos tested, and all of the embryos were positive. And our dilemma was how we relayed that information without disclosing the case of the status of the affected parent. But that's kind of separate from this issue. But I do think that if we have information at the time about the benefits of genetic counseling or the benefits of using assisted reproductive technology, that may help the patient to really understand what their ultimate goal was. And as someone else suggested, banking sperm, because not only now 20 years later, we do have pre-implantation genetic testing, or PGT, that could have been tested. But of course, if the patient is an affected carrier, and their prime concern is, not leaving their partner as a single parent, that type of genetic information wouldn't solve the problem. And it's an interesting point about whether or not informed consent truly requires a waiting period. Certainly, we know that a lot of people, the same is the case for women seeking contraception. If you can't give them what they need on that visit, they may never come back. But there's something to be said about the need to process this information to really understand it. You know, when we give people a cancer diagnosis, we always say they don't hear anything after they hear the word cancer. And so a lot of this information could be a lot to take in. And so there's no right or wrong answer for this, but something to consider if the patient's truly capable of making an informed decision, meaning they have informed consent and autonomy in the same day of getting all this information about options and a description of what the procedure is like and involves and potential reversibility.
Excellent points, Dr. Quinn. Thank you so much. Yeah, the patient was 18. His mom was just becoming devastated by her symptoms of Huntington's disease. He may well have been more relating to not wanting to be in his mother's position than not wanting, or for his partner's sake, than not wanting to be in his position, being a child with a possible genetic disease. Those are really good. So in cases that have complexities of information that are harder to understand and harder to process, giving it more time and calling into your assistance, counseling from geneticists or others, or psychiatrists, or people that can help the patient make a better informed decision that meets their needs and their well-being. Excellent. Thank you for that. Let's put the after poll up and see if people feel differently about their decision on this case. I'm sorry I didn't introduce the pre-poll, but I hope most of you saw it on your screen and got a chance to click on it. So after listening to the discussion, has your opinion changed or not changed? Or was it not useful discussion? Very good. And we'll tabulate those results. And then next we'll go to the third case, which is our own Doug Stein, also on the board of World Vasectomy Day, practicing in Tampa, Florida, who had an interesting experience some years ago. And Doug, go ahead and present that for us.
Thank you, Chick, and thank the whole staff of World Vasectomy Day. I think I can share my screen. Let me try. And let me go back. No, that means
Doug, I think we have your slides.
super.
Hang on just one
Okay,
second.
great.
Just give me one little technical.
Like Tony's, this is also a case that happened nearly 20 years ago.
Aquí está. Okay. Here we go.
But
And then the next slide, Doug, just one more minute. The next slide will be your whole long thing. This is so we have a little bit in Spanish as well to explain. So to give everybody a minute, this is the very, the summary of the case.
Yeah.
Okay, we can go to the next slide. Okay.
Thank you. This is pretty pertinent because it did happen so many years ago. I was training a doctor at a health department. He was the 12th in a long series, and he was having a little trouble on one side, which is usually my second side. So we said, well, let's start on that side. So we did that side, and it took him a little while, and it seemed like a long time had gone by, and we finished up, and that was it. We ignored side one. So my patients all had my phone numbers. I sent him a voice message. He didn't respond, never any complaints. But months later, he had a positive post-vasectomy semen analysis. I mean, feels packed with motile sperm. I met him during my next regular clinic visit, and I told him that, boy, one side sure feels normal. Perhaps maybe I didn't do it. Maybe I just overlooked it. I was training that day. So I offered to do it again right then and there, but he was angry. that he had gone through so much. Of course, I never heard about this so much, and he did not want to do that again. I had broken our contract, and that was for me to provide a bilateral vasectomy. Well, the guy reports me to the Florida Medical Board. Now, I call my insurance carrier on their advice and say, I have an unhappy patient. So I gave him the details and never heard a thing until a while later. I found out that they had settled with this guy for $5,000. Anyway, for the next 10 to 15 years, I had to report and summarize this case on every license renewal application, every hospital privileges application. I mean, it was hours of work over the next 10 years because you always have to report anything that happened in the last 10 or 15 years. Anyway, should I have told this guy that the vasectomy had simply failed? And what should I do if that ever happens again?
Okay, great questions. Let's put up the poll and see what people would say they would do if it was their case. And so Doug's asking, you know, what's the right thing to do in this situation? I think it obviously brings up a lot of questions, but principles of honesty and also beneficence. Did this really benefit the patient for him? For Doug to be so honest and tell them that they may have forgotten that side. I don't know if Doug was certain that he forgot the side or only thought that he forgot the side, but in any case, he was certainly trying to be completely honest and forthright with his patient. And it certainly invokes a lot of sympathy in me and probably in a lot of the rest of us in the room to have Doug have to go through all of this. Thank you, Doug, for presenting that. And there's the poll. Let's see what you would have done in that case. And who would like to speak? Nick Dimidik in Australia. Nick, can you?
Hi.
There you are.
Doug, I've got no idea how you could remember what you did at 6 weeks with the PVSA. It's mind-boggling. Why didn't you even go with the stupid third tube argument? You know, I mean, I've never seen this elusive third tube, but I would just say, oh, look, it's recanalized. Let's do it again. How the hell could you be goddamn sure that you didn't do it? And why didn't you figure that out in the first 6 weeks after the operation? You know,
I just thought that the case was a normal case, and I had to wait until I got the post-vasectomy semen analysis. But it's not like a recanalization where you get a few sperm coming through. This was like a normal semen analysis, and that vas on that side felt perfectly normal. It didn't have a gap or a lump or nothing. I hadn't touched it.
Okay, John Currington, would you comment, please?
There we go, unmuted. So I've actually had something similar to this, but you really during the exam, especially on a non-slender gentleman, can't really tell. Doug had the advantage of having great fingers, lots of experience, and being able to palpate very well that his tube was likely quite intact. But a lot of times on a guy with a little bit of chunkiness to him, you can't truly tell. So I think a reasonable middle road might be to say, I can feel your tubes. It's difficult to tell exactly what happened, but there's a few possibilities. There's a possibility for this elusive complete recanalization. There's a possibility I missed a tube, but for free, we will redo your vasectomy. So I think to relate all of the possibilities is not being dishonest, and can help you walk this middle ground between you're telling all the true possibilities and also making sure that the patient understands that we want to take good care of him.
Okay, and that might be to the patient's benefit to leave all possibilities open. What if it's not truly honest? What if you know exactly what happened? Is it not? And yet you think it's still probably to the benefit of the patient to tell him, maybe that happened or maybe these other things happened. What's the absolute duty to honesty in this case? Anyone want to comment on that? Doran Boone. Doran?
In the UK, we have a duty of candor, which means that if we suspect or if we have knowledge that we should be sharing with the patient, then we are obliged to do so. Obviously, this does not relate to the previous or the first case when we heard about Michelle's nurse telling us about information that was confidential and shouldn't have been passed to us. But in this case, if we genuinely thought that we had not operated on one of the tubes, I think we have a clear obligation to tell the patient, even though it will cause problems for ourselves. However, having done many vasectomies myself in a busy clinic, you sometimes, and we have mentioned this previously in the Google group, we don't always remember whether we've done one or two at the end of the procedure. And this is one of the advantages of removing a small section, that we can look on the tray and say that, yes, I can't remember doing the first side, but there are two pieces there, and I can reassure myself that I've done both sides. But that's the nature of maybe.
Yeah, very good. And if you were,
and what else?
No, that's very good. Thank you, Doran. And I love the way that Brits have these lovely words. Duty of candor is elegant. That's great. I was just going to say, if you knew you'd only done one, you could split the specimen in half and send it in. But that wouldn't be right either. I'd like to thank you all for your comments. Anyone with another quick comment before we turn to Dr. Quinn? Tony, you have something to say?
Yeah, I mean, there's also the question of for you, Doug, as regards how you would have felt if you'd done nothing and just repeated it and just said it's recanalization, because you yourself would have actually had a bit of a guilty conscience, which would have stayed with you for the next 10, 15 years. Was that a price to pay?
I'd rather answer how would I handle my second case of that 10 years later, Tony, and I wouldn't have any qualms at all about telling the patient, boy, you know, that vas really feels like it's back together again. And let's do that left side. And I would not have any qualms at all about saying that. Consider me perhaps a less ethical fellow than yourself, but 10 years of filling out forms was too much.
Exactly. So that's it. Dr. Quinn is
absolutely certain it was a mistake, they also need to know that they may choose to go get their care regardless of the free service that you might be offering them with another physician because they've lost trust, but they really need to know, you know, exactly what the parameters are. And sometimes, you know, patients are pleased, and that invokes even more trust in the physician when they are given honest information.
right, and it also would impact your decision if you were saying, well, maybe it's a recanalization. You can't be sure of which side was recanalized. Certainly, based on your exam, you'd have to do a bilateral vasectomy. Whereas if you knew it was the left side that you hadn't done, you would just do a repeat unilateral vasectomy, right, Doug?
No, with failures, I sometimes just do a unilateral vasectomy. If there's a clear gap on one side and a nodule on the other side, I usually just do the nodule, and then I've been right so far, maybe 3 or 4 times.
Man, you are good. I can't tell that by feeling, but that's good to know. Thank you, Doug, for that insight. So the post poll on this one is that what we're seeing now? I'm seeing it in Spanish. I think is that I think so we're doing the post poll now on this case, and I want to turn this back over to Deidre. This has been amazingly stimulating and thought provoking. It's also wonderful to see you all face to face after a lot of correspondence we've had online over the course of the years. Thank you, and Deidre, take it from here. Let's see, Deidre, did you go for a sandwich or are you still around? Okay, I think Deidre.
No, I'm talking. I'm sorry, I was talking away, not realizing I was mute. So
thank you.
I'll start over.
And I didn't see your photo. There you are.
Yeah, thanks, you guys. It's really been a great day. This has been a very interesting thing. We didn't know how today would go because we haven't done one like this. But I think the idea of a discussion is a good one. Physicians like to talk to each other about their cases. There's no doubt about that. And in this case, when you have an ethical component that may or may not be clear, I think sharing ideas is a really valuable exercise for all of us. And even for those of us who are not in the medical field, looking at ethical questions and trying to weigh the consequences ourselves is a great exercise. So thank you all for your contributions. I really appreciate the questions, the chats. We're gonna bundle this all together so that you can revisit it if you want. And you're well, as I said, I'll keep the lines open for another 30 minutes. If anybody wants to just stay and chit chat, that's fine, or talk about these particular cases. In closing, I'd like to remind you to save the date for the 3-hour presentation at the summit. We're going to have this year a session on the latest on prostate cancer and vasectomy. Is there a connection? Is there not a connection? We're going to talk to a company that is going into clinical trials, human trials for a temporary vasectomy technique that we think will be of interest to you. And we're going to have some breakout sessions, which are going to include some basic training with live vasectomies in English and in Spanish for either medical students or doctors that have recently graduated that might be interested in vasectomy and knowing more about it and how to do it. And we will also then have some other breakout sessions with other things that are specifically vasectomy related. Again, thank you for your attendance today, and please fill out the evaluation forms. That makes a difference to us, and we really appreciate your attendance. Thanks.
Deidre, you want to say the date of that next?
November 13th.
Thank you.
And we'll be sending out plenty of announcements, but November 13th, just save the date. It's going to be fun.
Yes, thank you, everybody. Thank you, Dr. Quinn.
Thank you, guys. Yes.
Thanks, everybody.
Hey, I had one last thing.
Yeah, go ahead.
This is Jonathan. I just wanted to, I thought that was really amazing. It's exciting to see people from so many parts of the world participating. It's really fantastic, and wanted to thank all the people who pulled it together. And just to remind everybody, there's a lot, you can see the slide that Deidre's put together. So there's a really big, going to be a very ambitious year this year for World Vasectomy Day. And, we really count on you doctors for all the work you're doing. So, keep it up. Let us know. We'll keep trying to, share more information with you and provide more, resources to help you, build your clinics and your practices, some all over the world. This is really awesome to keep this going. And I think, the sort of having these ethical conversations, like, just really, I think really interesting. That's certainly for myself, just contemplating this. So I really wanted to thank you, Dr. Quinn, for joining us and providing that kind of insight. Is really tremendous.
Great. Okay, so we'll close the official session and then move on. Thank you very much for the claps. That was nice. our staff, but it'll be really, it'll be interesting to see what we come up with for the rest of this chat afterwards.
Did Dorn Boone want to talk?
Yeah, Dorn, do you want to talk? Now we're open mic. We're going to just use an open mic system from here on out.
I didn't have any particular comments other than to say I very much enjoyed the session today, and there are very interesting cases. Thank you so much, Deidre, and you're looking younger and more beautiful than ever.
Thank you, Dorn. Yeah, you can come anytime. You're always welcome. Okay, who we got left? And we got Nick. Wow. Hey, Nick.
Nick.
Hi, guys. How you going?
He got up at 6.
Yeah. That was good. This 4 o'clock, that's fantastic for me. It was way better than the 2 o'clock in the morning one.
Yeah, we've still got, and so there are still 85 of us in the room. And I would like anybody to suggest whether you want to revisit another case. Should we go back and look at some of the cases that we've already talked about? Or do you want to tell us what you're doing, what's going on with you? You can give us other cases that you have had trouble with. The mic is open. You can take your mic off and just talk.
Oh, I just wanted to make a comment about this. This is obviously this was a great experience having to share, being able to share these cases. Obviously, there are many more cases that we all encounter, but it just goes to tell you how such a tiny procedure with such a huge impact, in the life of a person, has so many aspects that we can discuss about. Obviously, we can spend the rest of the day and the whole week discussing about the ethics related to vasectomies. I mean, it's not just what's related to the relationship directly with the patient, but also the motives that vasectomy in general, reproductive sterilization procedures have had over the years, right? Eugenics amongst those, and how that's a dark period in the history of sterilization procedures, but many other things. I mean, it's fascinating all we can learn from performing this tiny procedure. Every single day, I'm fascinated more and more about doing this. So I just want to bring that up because it's just great, and I love having the opportunity to share with so many people who share a similar view on the procedure. That's just so enriching.
Yeah, I'm reading the chat a little bit, and I just see that there's one comment that says, leaving ethics and code of conduct aside, if a lie doesn't harm my patient, I would do that to protect my reputation and career, and then make sure never to make such an error again. And I think that's sort of what Doug came up with at the end, that the impact to his own career was so huge that he wouldn't be willing to go through that again. And I think that's a real ethical fine line about how you would do, each of you have to choose. Your career really matters to you, your reputation, and we all make mistakes, right? So every situation is, of course, different. But if anybody has any comments on that, I really think that's the meat of the matter.
Yeah, I do. I think, I mean, I've probably been practicing longer than almost anybody on this screen. And I've made my share of mistakes, so probably maybe more than anybody. I don't know, but notwithstanding Doug's case, which was I'm so sympathetic to. My policy has always been to be forthright. I love the term duty of candor, and I guess to some extent it protects ourselves from feelings of guilt or bad conscience later on. But what I can say is that having talked through everything with all of my patients that I've made known mistakes on, the results have been tremendously gratifying for me. The way I have been embraced by my patients that had bad outcomes, more so than any of my patients that had good outcomes, has been heartening and fulfilling to me as a physician. That's why I'm still practicing medicine at age 72. I feel like not only have I been a servant to my patients over all these years, which is a good thing, but they've bolstered and supported me in ways that I never could have had I been doing another career. So I think honesty has paid off for me personally from a fulfillment point of view.
Yeah.
Dick, I will add that I probably would not have even remembered my case had he not been a litigious guy. I think 99% of my patients would have said, "Oh, doc, don't worry about it. It wasn't a big deal anyway. Just go ahead and do the other side." And that's what I thought that this guy would do, because I guess I hadn't gotten into the mind of the litigious sort of guy, because if it were me, I would have said, "Oh, doc, don't worry about it. I healed fine from my other one. My wife still has in her IUD, or I still have a couple dozen condoms left. I can wait another few months, no big deal." But this guy, who had no untoward effects of his unilateral vasectomy, somehow was just ready to nail me. And
that's why it's a good case to discuss, Doug. Totally unexpected, and you of all people I know are so straight out and forthright and honest and engaging and personable. Is just
diligent.
Well, thank you.
Can I say something?
Sure.
Sure.
Yeah, I'm Sri from the United Kingdom, from Rugby, and I have seen Doug in one of the conferences. So I have learned a few techniques from you, Doug. Thank you for that. And thank you for the wonderful various webinars you've been putting together. I just have a sort of a comment on Doug's training. So as I train trainees as well, they do make mistakes. So at what point do you tell the patient that this is a trainee, is likely to make a mistake? And if the trainee makes a mistake, yes, it's your neck on the line. So what would be your approach when a patient comes to you? I've had a patient come and said, "Oh, you should have told me the trainee was doing the operation and not you." And he was furious because he had a hematoma, but I have to take the blame for it. So what is your approach when you're training your trainees with regards to telling the patient who's doing the operation? Because it's done under local anesthetic, the patient is awake. So I'm just curious to know what you do in that sort of situation when you have a trainee and you've got a patient who is likely to have a problem.
Well, all of my training patients know that they're training patients long before they come to the office. They register online and they're given a $200 discount. Now,
okay.
that's one advantage that we have over, let's say, some single payer systems, such as maybe Canada and the UK, maybe Australia, that I can sweeten the pie for patients to be training cases. Whereas in other countries, if it's a single payer system and all patients are going to be the same, and I can't offer the patient a discount because it's already paid for no matter what, then maybe I would have trouble, being a training provider. But all the patients know long in advance before they come to the office. We have a special page on the website dedicated to physician training and what they can expect. In fact, we schedule my cases 15 minutes and the training cases 45 minutes. So they're being paid essentially a $200 discount to lay there for 45 minutes instead of a much shorter period of time.
Okay, we don't have that.
Right.
Well, I applaud Doug. I mean, my goodness, nobody does as much as he does for training people in vasectomy and so forth. I don't train as many people with hands-on in vasectomy. I've done a lot of workshops and things, not on patients, but I've done a lot of surgical training of family medicine residents in clinics and so forth. And my philosophy about it is that the teaching case should benefit the patient about equally or better than if there was not a trainee involved. So it's our obligation as trainers in that setting to number one, make sure that the trainee is not making mistakes. I mean, that's it's not just see one, do one, teach one, which is that old joke really about training in the United States. I really hold a trainee accountable to a high standard of care, even when he's learning. So I don't let him touch the patient until they've demonstrated their skills. And then the patient should hear your training talk, and our patients seem to love it when I'm talking to my trainee about meticulous little aspects of exactly what we're doing And I think when they walk away from that, they do feel like they got better care. I hope they do. Of course, if they have a complication, they may not be very happy about it, and they may blame it on being a guinea pig.
We allow the patients to watch. I mean, even the training patients,
right?
Half of them will lift themselves up on their elbows and watch the case. The wives are welcome to come in the room. So we do, Chick, we do turn it into a training case, not only for the trainee, but the patients enjoy learning about how to do a vasectomy. And, you know, you can imagine them discussing that at family gatherings and cocktail parties about what happened during that. So we don't really have too much of a shortage of people who are willing to be training cases. I can't tell how much of it is altruistic. We know that some guys come in and they've already met their deductible. They're not saving any money, but they say, and usually these are the healthcare workers. They're like, you know, nurse practitioners or PAs. You know, I train myself and I know how important it is to have patients, people who are willing to be training subjects. So here I am. So people are very.
I think your transparency probably helps them with that, Doug.
Thank you for that.
So yeah, I think so too. But I will say that when I'm training, I always have a hemostat in my hand, ready to grab that dropped vas with a bloody blood vessel alongside of it that's going back into the scrotum. So I don't, you know, I'm watching them so carefully that I realize how vulnerable I am to the situation.
Yeah, it's like a driving instructor. You're on the other side and you have to press the brake.
That's right. Yeah,
and you don't have a brake.
Your hand is the brake.
Actually, I would probably say that it's almost more ethical to train someone for vasectomy. The patient is awake. He knows that there's a trainee. When you have a surgery in a university hospital, a lot of patients are probably having their surgery by a resident, and they will never know that it was done by a resident. So it's probably even more ethical to do training on vasectomy.
That's right. I agree.
You know, and I wanted to share a case similar to yours, Doug. It was a morning I was training resident in urology, 5th-year resident. So it was pretty good. It was, I think it was his 3rd session with myself. So I just let it do the surgery. And that morning on 11 patients, he did 2 patients where he did the same vas twice. Ooh. And so I had 2 recanalization that morning. And I'm going to tell you the truth. I didn't say to the patient that there was a mistake, but I could feel exactly what you did. I've got 2 little lumps on one vas and no lumps on the other one. So I did both, but so it happens.
I think having the presence of the partner during the operation it's something that I always welcome, but it's also a source of stories that I'm sure that we as vasectomy surgeons can recount. Wives fainting onto their husbands during the procedure, or women that are so enthralled by the operation and asking whether they could watch another one. That is the next patient's vasectomy. And on many occasions, I've told the partners that I'm actually recruiting at the moment for the chief willy holder. And they look so enthusiastic. Often,
Doran, I think it's your suave demeanor that they want to experience again.
No, I wanted to comment on something that Chick said about Doug's case, because it's knowing how Doug approaches the patients, and just totally unexpected with that kind of patient. With that patient particularly, is that litigious patient that Doug was talking about, that personality that you probably didn't see coming. Because one of the things that I've learned is that when you are engaging, the way that many of us are when we're doing the vasectomy, when we have the partner, that we basically walk through the partner we worked the pattern through the entire process. It was like, we're doing this, next time I'm going to do this. You know, I'm pulling here. You see, I'm using the same opening. I'm pulling here to show that it's the left testicle. And now I'm pulling here to show it's the right testicle. You know, all that process, you know, we do it not only because we enjoy what we're doing, but, you know, also because we protect ourselves. You know, we have a witness there. We have the partner witnessing the process and seeing the meticulous approach that we have. So they actually are on our side, you know, because we're doing the right thing. But a patient like that, you know, blindsides you, you know, because
Unexpected.
it's totally unexpected. Yes.
At the end of the operation, after you've explained it all in meticulous detail to the partner, I always say, and now I'm going to have to kill you because you know all my secrets.
That's a good line.
Yeah, I have a question for all you learned trainers there, if I may. I'm looking at, say, if you're training somebody, like say somebody's having a driving test. Driving lesson. You do that driving lesson every day for say 2 weeks, and they become an expert almost and pass their driving test, versus they're having one driving lesson once in 2 weeks over a period of say 6 months. So I'm getting a trainee coming to learn vasectomy just for 2 days. He's going to have 14 cases over 2 days versus somebody I've had over 6 months doing once a week, once
definitely
2 weeks. So how would you sort of compare from your experience? Because I'm trying to compare these. So I've got 2 trainees who I've trained who were posted as GP registrars over a period of 6 months, and I've signed them off for their necessary numbers. Whereas I'm getting a doctor from Ireland just coming for 2 days because that's all he can come for. So I have to accumulate 14 or 20 cases over a 2-day period. So he has to come and learn and then go away. So in your experience, how would you compare your methodology of approach for those 2 scenarios?
I'll just tell you something quickly, and then Doug will be the authority on this. But I don't offer training in my office on my patients for outside doctors. The only time I train in my office is for our own doctors, and that's only been a couple of partners I've trained. But I've done when I was doing American Academy of Family Physicians workshops, I had many doctors who asked me to do not mentorship, preceptorship in their office on patients so that they could learn vasectomy. And that always worked very well to do. I would say, okay, I want you to get 10 patients, see them, consult with them, get them all ready for their vasectomy, and then have them all show up on the same day on a Saturday. I will fly in and we'll do 10 vasectomies in a row minimum. If you can get more than that, that's great. And you may have to give away free vasectomies. Go to the Planned Parenthood, go to the public health department, say, we're having a vasectomy training day. I'm doing 10 free vasectomies. Anyone you can send me, and line them all up. And I'm having the skilled Dr. Wilson doing it. So it's not just the trainee situation. So in those, that's the way I set that up. That worked very well for those doctors to get bam, 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 bam. And boy, I think that is the way to get excellent training.
Yeah,
your opinion?
Yeah, I do. I think batching cases is really worthwhile, not only during training, but I think it's good after your training. I always say to people after their training, now don't do 1 vasectomy a week, do 4 vasectomies together once a month. You know, if your patient load is 4 vasectomies in a month from your limited clinic, put them all together, because you just start to get into a rhythm when you're doing 1 vas after. You got to be sure not to forget a side if you get in too much of a rhythm, but
right,
rhythm about it, and you remember what your shortcoming was on case number 1, and then you try to strengthen that on case number 2. But if they're separated by a week, then you don't remember the problems that you had on case number 1 because it was a week ago. So we find that the same is true in a training scenario, that I do as you are about to do. I usually have a trainee for 2 or 3 consecutive days, and we alternate cases. I do 1 trainee, and then I think they really benefit from the night in between training days. They kind of, the first day they're kind of blown away because they thought it was going to be easy and it really wasn't. And they seem to they seem to, all my trainees seem to agree that having a break of one night between groups of patients was worthwhile.
Thank you for that.
I attest to that. I went through that process with Doug, so I agree. And actually, I'm glad that Chick mentioned that approach. I did that training with the GYN at Planned Parenthood, and they were the ones, they wanted to come with me, and I said, no, not in my clinic, but they were willing to recruit all the patients through Planned Parenthood, and I went to their clinic, spent 2 days with them, and we did about 22 vasectomies in those 2 days, and it helped. You know, having them close together like that certainly allows you to fine tune what you're doing.
Right.
Thank you for that.
Well, this has been great. I'm thinking we pretty much need to wrap it up. Our translator actually needs to go home, and I'm sure some of you have other things to be doing at this point.
Thank you.
Thank you so much for all the input. I really love that we do this. I think it's really great to see all of you and to just know you're out there and to be willing to help each other. It's a beautiful thing. So once again, thank you for coming, and hope to see you soon in a month or two.
Thank you.
All right, everybody. Thanks for moderating.
Thank you. Thanks, everybody.
Bye-bye.
Bye. Thank you.